My name's Tony Grayson. I work for Inspira Health, and I've been asked to present our work that we undertook with Luton Clinical Commissioning Group to do with a consultant cardiologist-led programme to reduce atrial fibrillation-related stroke. A bit of background about myself. I've got 20 years experience in the NHS in a number of faculties, including clinical audit, health informatics, and research with over 80 peer-reviewed publications. In terms of conflict of interest, as I've already alluded to, I'm a member of Inspira Health, and for this work I received funding from DS for setup costs and staff salaries. The background to the work, we already know from well-published research that around just over 1/3 of patients with AF are not on the correct anticoagulant treatments. A number of them usually on just antiplatelets. And we also know from the NHS long-term plan that in every 100 patients with AF who are treated appropriately with anticoagulation, that we on average can save 4 strokes in that patient population. It's quite an important part of the long-term plan. From a Luton perspective, they also knew that from data published in 2018 by the Stroke Association, that they, on an annual basis, were having around 39 patients with known AF-related strokes. So it was an issue that they wanted to address. So the objective of the work was to ensure that patients with AF are appropriately anticoagulated across the Luton Clinical Commissioning Group footprint, with the primary goal to reduce those AF-related strokes. So Luton CCG approached Inspira Health to adopt their primary care atrial fibrillation service, which is a 5-phased model of delivery, completing an audit cycle. Phase 1 of the process is system interrogation, which basically involves running bespoke AF queries on the clinical systems across the GP practices, and then go on to phase 2, which is completing a very comprehensive case note review of all the electronic patient medical records of the patients with AF. And there were 3 components to the audit. The first being looking at anyone with AF who wasn't actually already on an anticoagulant and determining the reasons for that and those that would be eligible to be anticoagulated. The next component was looking at warfarin patients, assessing their warfarin management and their INR variability to see whether any of those patients would actually benefit from being on a more modern day DOAC. And the final component was actually reviewing all those AF patients already on DOACs who may have actually been on the inappropriate dose based on the patient characteristics, and double checking that their renal function was up to date and still compliant. After the audits were completed, relevant patients who needed a consultant cardiologist review were invited to come into their GP practice for either face-to-face consultations, or if that wasn't possible, they'd go on to have a telephone consultation instead. Phase 4 of the process was the actual consultant reviews themselves. So as I say, the patients would be invited into the local GP practice, and when we were able to actually hold the clinics at the GP practice, this enabled opportunities for the GPs themselves or other members of the practice to join in the consultation so they could get some one-to-one clinical education with the cardiologist. The main purpose of the clinics was obviously to ensure that patients with AF were on the optimized AF treatment for anticoagulation. And phase 5, just to complete that audit loop, after 2 months of every clinic, we would go in to review that all the recommendations and all the actions from the clinics had been completed, and we'd be able to help the GP practices ensure that that was all done and finished. So in terms of GP practice enrolment, this was a voluntary scheme, so GP practices were not obligated to participate, but Luton CCG held educational sessions and meetings across their patch with GP leads and made sure GP practices were given appropriate information in our PCAF flyers so they would understand the benefits of actually participating. And any practice that enrolled was then given a full comprehensive protocol, which would detail actually what was going to happen and all the requirements for completing the process, and whether we'd do it remotely or whether we'd come into the practice to do everything there. After agreeing the protocol, practices would obviously sign up to our data sharing agreement, which is GDPR compliant and ticks all the relevant IG tick boxes. And they'd get a compensation letter for their approval, and if they wanted to, they could make some amendments accordingly. And finally, that letter would then go onto their GP letter-headed paper, so the practice was fully engaged in the invitation process. So on to the results. So overall, we had 21 practices who enrolled into the programme, and their AF prevalence was 1.2%. Obviously, it was quite varied, as you can see on the chart shown. But the practices that enrolled represented 81% of the Luton primary care population. In terms of what that AF prevalence equates to in terms of number of patients, it came to 2,274 patients. And as I say, that was quite varied from practice to practice, with the smallest number being 11 in one practice, to the maximum being 272 patients with AF. Now, of those patients diagnosed with AF, just less than 80% were already on anticoagulants. And for those patients on anticoagulants, it roughly worked out to be a third who were on warfarin or vitamin K antagonist type medications, and 2/3 that were on the more modern DOAC medication. We reviewed extensively the patients who weren't on any anticoagulation at the beginning of the process, and that was 485 patients. And we found that just over 60% of those patients weren't actually eligible for anticoagulation. And there was a variety of reasons for that, but the biggest being that there wasn't actually any evidence to confirm the patient's AF diagnosis in the medical records, so therefore it wasn't appropriate for the cardiologist to actually proceed. Therefore, we didn't invite them in for the clinical reviews. But other reasons were the fact that they were just a CHA2DS2-VASc score for gender only, and obviously they're not eligible for anticoagulation. But AF resolved as well was a reason, and obviously there was patients who were contraindicated for anticoagulation. In terms of those that were already anticoagulated at the beginning of the process, of the warfarin patients, we found that about 14% of those patients were suboptimally managed. That was looking at their TTR range of less than 65%, and also looking at any variable INRs with 1 above 8, requiring a discussion about the change, or 2 above 5 on the INR, or whether they were actually suboptimally low on the INRs, so if the 2 values were 1.5 or less. In terms of the DOACs, we found that 10% of DOAC patients, so 122 of those patients, were actually on the inappropriate dose. They were either underdosed on the DOAC medication or dosed too high based on their age, weight, and renal function characteristics. So overall, from all of that, 399 patients were actually invited for a review with a consultant cardiologist at their GP practice, and the attendance rate was around 72%. We obviously predominantly tried to do face-to-face consultations with as many as we could, but any patients who couldn't attend the consultation had a recommendation left by the cardiologist in the patient medical record for the GP practice to consider and discuss whether the patient would wish to initiate anticoagulation. Obviously, with this work ending in April, COVID-19 became a slight problem in the last month of the process, and we effectively just switched all face-to-face consultations at that point to telephone consultations, so patients could stay home, protect the NHS, and save lives. So after the clinics were completed, the outcomes from the 399 patients, we had 354 patients that had anticoagulants prescribed, or they were changed onto an alternative anticoagulant, or the management of INRs were improved through education and discussion about habits that might influence the variability of the INRs. And we also made sure that DOAC doses were increased where necessary, so people weren't being inappropriately underdosed. So going back to what I said at the beginning of the presentation, in terms of we know from the evidence that 100 patients with AF, if they're appropriately treated, that we can save 4 strokes for every 100 patients, so it's effectively 1 in every 25. So from this work and the success of the clinics, we would expect from this to have 14 AF-related strokes prevented. We'd expect 8 lives to be saved, and a cost saving to the NHS of just over £300,000. And again, alluding back to what I said at the beginning of the presentation, that we know from the Stroke Association that for Luton CCG, that there was usually around 39 patients a year with AF-related strokes. So we'd expect from all of this that there would be a 36% reduction in the stroke incidence. So in conclusion, a consultant cardiologist-led programme across GP practices in Luton CCG has enabled improved anticoagulation to prevent AF-related stroke. Thank you very much.